I would like to share my presentation and to shed light on the adverse effect of an important drugs which are the non-steroidal anti-inflammatory drugs. As دكتور منال سبقتني وذكرت الادverse effect باعتبار responsibility of pharmacovigilance. This is a study for the effect of Etoricoxib versus Diclofenac on blood pressure in hypertensive patient. As you know, non-steroidal anti-inflammatory drugs, both selective cyclooxygenase 2 inhibitor and non-selective types are among the most frequently used medication. Most doctors prefer the selective types because they are well known to have fewer side effects. However, the potential correlation between their use and the elevation of blood pressure are not well determined. The non-steroidal anti-inflammatory drugs are classified according to the mechanism of action into non-selective COX inhibitor like indomethacin, diclofenac, naproxen, and ketorolac, and the old generations of non-steroidal anti-inflammatory drugs. While the newer selective COX-2 inhibitors like Celecoxib, Rofecoxib, Valdecoxib, and Etoricoxib are known to have fewer side effects on the gastrointestinal tract. Non-selective non-steroidal anti-inflammatory are chemically heterogeneous group, composite that offer considerable health advantage in the treatment of pain and inflammation. However, their use can be associated with an increased risk of gastrointestinal and cardiovascular side effects. Selective non-steroidals act by inhibiting only the COX-2 enzymes, thus permitting the production of prostaglandins by the COX-1 that protect the stomach, while still relieving pain and fever as well as inflammation. Though they do not exert the antiplatelet effect that is associated with the non-selective non-steroidals, the effect of selective COX-2 inhibitors is more than non-selective on prostaglandin I2, which is synthesized in the kidneys through the COX-2 enzyme that lead to an imbalance between the effect of prostaglandin and prostacyclin. As you know, prostacyclin has an effect on the vessels as a vasodilator that subsequently increase vasoconstriction effect on the cardiovascular system. This diagram shows the mechanism of types of cyclooxygenase enzyme on prostaglandin. The precursor arachidonic acid in the GIT mucosa, the COX-1 enzyme effect can lead to prostaglandin E2, which is effective in gastric protection, and COX-1 inhibition can lead to peptic ulcer and GI bleeding. While in the kidney, COX-1 and COX-2 are present and lead to the formation of prostaglandin E2 and I2. These are afferent arteriolar vasodilation, and COX inhibition can cause water and sodium retention, hypertension, and hemodynamic acute kidney injury. In the cardiovascular system, also COX-1 and COX-2 can lead to prostaglandin I2 and thromboxane A2 production. Vascular effect of prostaglandin I2, which is prostacyclin, can lead to vasodilation and inhibit platelet aggregation, while the effect of thromboxane A2 can lead to platelet aggregation and vasoconstriction. So there is a balance between these two prostaglandins. COX-2 inhibition, more than COX-1 inhibition, may lead to stroke and myocardial infarction. The aim of our study is to compare the effect of selective COX-2, which is namely Etoricoxib, versus the non-selective, namely Diclofenac, on blood pressure in patients with hypertension, which are already on antihypertensive treatment. They are requiring the use of either selective or non-selective non-steroidals. This prospective observational study was conducted on 100 patients with hypertension already on antihypertensive treatment. They were divided into two groups, 50 patients each. Those who received Etoricoxib in group 1 and those on Diclofenac in group 2. They were followed up for 2 weeks to observe the changes in pulse rate, blood pressure, and renal indices. What are the results? This is the demographic and clinical characteristics of both groups at the baseline, which were no significant difference between the clinical characteristics between two groups, group 1 and group 2. This is the clinical data of both groups after treatment using non-steroidals. Regarding group 1, which is on Etoricoxib, the systolic blood pressure became 134, and 143, and group 2 became 136 in Diclofenac, which was significantly different, while the diastolic blood pressure, pulse rate, blood urea, and serum creatinine were no difference. This is the changes in clinical parameter from baseline in both groups after treatment. We notice that there is elevated blood pressure in 32% of patients on Etoricoxib, which is about 1/3 of patients have elevated blood pressure, in comparison with the group 2 Diclofenac group, which is 12%, which was significantly different. Systolic blood pressure change also were different. Also, the diastolic blood pressure were significantly different in both groups. In Etoricoxib was more elevation in blood pressure. There were no changes in pulse rate, blood urea, and serum creatinine in both groups. This diagram shows the changes in clinical parameter. We notice the elevation in blood pressure were more in the group 1 in selective non-steroidal anti-inflammatory drug. Conclusion: this study concluded that the selective COX-2 inhibitor has a significant effect on raising blood pressure in hypertensive patients, more than that of non-selective one, with no significant difference in raising pulse rate and renal indices. Our recommendation: although many physicians frequently prescribe the selective non-steroidal anti-inflammatory drug, and in patients with hypertension, many elderly patients need rheumatological treatment in the form of either selective or non-selective one. And also many doctors prefer the use of selective ones because of their well-known fewer side effects, but their use are demonstrated to increase blood pressure more than the non-selective ones. So it's recommended to suggest on the rheumatologist and the general medicine that to choose the non-selective type, non-steroidal, whenever required for patients with hypertension. And thanks for listening.